Good afternoon, ladies and gentlemen. Now we are talking about the quality of life after heart and lung transplantation and how important is the physical training. I'm a professor here at the University of Helsinki. This is main building. And here is a medical science center, Biomedicum Helsinki, at the Meilahti campus. And here are most of our activities at the Helsinki University Medical Center. And we are renovating all time. There will be more and more new buildings, and more activities are moving to this, we are calling it nowadays, Academic Medical Center Helsinki. We know that when we have very sick heart, our patients are doing very poorly, and as well as our lung patients, when they are getting sicker and sicker, normally it takes longer than with the hearts to go to the very bad situation, and therefore our lung recipients, normally they have lost already most of their muscles. We saw just in Krista's presentation that the first heart transplantation was made 85, and heart and lung 88, and then finally 90 single lung transplantation. And we have very many very well doing patients after transplantation, as well with hearts and also with lungs. How should we measure clinical outcomes and management? Survival is clear, patient is alive or dead, but quality of life, it is a little bit more difficult to say what is the most important thing in the quality of life. There are very many instruments what we can use. Here we can see the top transplanting countries in the world, and Finland is behind other Scandinavian countries. There is Norway on the top, and then Sweden, Denmark, and then Finland. Donation from deceased donors in the world, there Finland is doing a little bit better. We are the second country in Scandinavia. And here you can see brain dead donors in Nordic countries, and this red line is our line in Finland. We are doing quite well, and we have been doing quite well, especially last year compared to Norwegian, which usually are the top country. There is a little bit similar transplant of, I can't see now which one it is, but looks same, pretty much same as the previous one. Hearts, just hearts. And here we can see transplantation performed in the Nordic countries all together. There Finland is doing less than all the other Scandinavian countries. Here we have adult heart transplantations in our center, and you can see that we have quite well patients who are evaluated and listed, and then we can see also how we are then transplanting. And there are some top years. There was early 90s, we did the best year was almost 40 heart transplants a year. And what are the indications? What kind of patients we are transplanting? It also is affected, and it has a meaning how the patients are doing after transplantation, what are the indications. And most of our patients are diabetic cardiomyopathy patients, then comes coronary artery disease, and then very few other diagnostic indications. And you can see that most of our patients are male patients, not so often compared to before 1999 years, but still there are more men than women transplanted. And how old are patients? Also, that means that what is the quality of life if we are transplanting very old patients. Of course, the quality of life is related much more a little bit and other things than the younger patients. Most of our patients are under 60, 40 to 60, and then younger, of course, but very few over 70. And in Finland, we don't have very long waiting times on the list. Here you can see that the average waiting time for heart transplantation is less than a year. It's like 8 months. And how are our patients doing after transplantation? If we are looking at the mortality rate, last year it was 0, and it a little bit varies, but it has, as you can see, our patients are doing better and better year by year. Here is the comparison to CTS results, and we are doing a little bit better. Our patients are surviving 10 years, almost 75%. And also there is a difference how we were successful before 2000 and then after that. Nowadays better. And 1 year results also. There is also improving results during this later period. And what is the reason for death? What are the diagnostics? You can see that chronic rejection is the main thing. And then this is primary graft failure. It means that the patient is not doing, all organs are slowly getting to the bad condition and patient dies. And then there are infections and malignancies and some also other things like you can see there are many other things what are the reason for the death after transplantation. And we know that cancer is very important thing when patients are alive longer and longer. And here you can see this our national cancer registry. And there are 3 cancer cases during the first year after transplantation before 2003, and 155 cancer cases in 106 heart transplant patients. And what are the main cancers? You can see the oral and pharyngeal, then there are skin other than melanomas, and then non-Hodgkin's lymphoma, but also some other. And here you can see after heart transplantation there is bladder and urinary tract, then lip, and then there are lymphomas and skin, also non-melanomas. Then a little bit about our lung transplant patients. Here you can see that we are doing much less lung transplantations than the other Nordic countries. Here you can see our listing. It's not that much different compared to other countries. And then finally, we are doing much less per million people lung transplantations here in Finland. And you can see that we are evaluating quite few as well compared to what we are doing. Then heart and lung, combined heart and lung transplantation is very seldom today. All over the world, there are less than 50 heart and lung transplantations performed. Earlier it was more common, but nowadays we can, if a patient has a lung problem and some heart problems, we can still leave the heart in and just transplant the lungs. You can see that the numbers have been changing. There are even 1 year we didn't any, but nowadays we are doing about 20 lung transplantations per year. And also our waiting time is much less than in the other European countries. And indications, most indications you can see, there are a little bit difference compared to if we are doing single or heart lung or double lung. Nowadays we are doing mostly, almost all our patients receive 2 lungs, and there is fibrosis is common indication, and emphysema, and then there are smaller numbers. We don't have so many cystic fibrosis patients, and therefore we are not doing as many as in most countries in the world. And survival, you can see that double lungs are doing better than single lungs and heart lungs. And also here we have nowadays much better results than in the early years. And how are our patients surviving? You can see that those patients who don't have previous ECMO, it means extracorporeal lung assistance, mechanical assistance with pump and oxygenator, these patients are doing better who don't have them used before than compared to those who need ECMO treatment. We did also quality of life study to our patients to predict the good outcome of transplantation. Especially we measured the effect of physical activity on quality of life after transplantation. We had 4 questionnaires, short term, the short form, general quality of life, gastrointestinal symptoms. They are important problems related to quality of life. And then we had this Finnish questionnaire. And also, of course, we were looking at the relevant clinical data which was collected from the patients. I don't go here to the exact methods so much, but you can see here that our patients were answering to our questionnaires extremely well. We did this study together with our Heart and Lung Association, and you can see that there were 80% rate to respond or more in all these our patients. And you can see that, of course, most of our patients were heart transplantation patients. And most of them were male, age about 50 years, follow-up time quite long, almost 9 years, and weight was not that abnormal. It was BMI was almost normal, and most of them were still married. And there was one student, 29 working, 2 unemployed, but most of our patients are on pension. It means that most of patients are so sick that they have been suffering years and also went to pension. And after operation, and even if our patients are doing well, very few go back to work. I don't know, is our system somehow problematic, or what is the reason behind that? What the patients who were doing something, there was one student, 23 at work, these most are retired, but only 6 were unable to work, and only 2 unemployed. But these are fine things. We have our Olympic Games and European champions and so on. Immunosuppression was quite normal, as many are using the same drugs, and at that time we tried very much to get the patient off the steroids. Even now, but I think we have come back a little bit to that small amount of steroids, at least in lung transplant patients we are using. How the patients were doing. The ejection fraction was very good, was average 63%, and maximum best was 82. It is very good. Ejection is a contraction of the left ventricle. Diabetes and malignancies, obesity, kidney function, etc. The more common comorbidities. 15 had malignancy other than in skin, and 26 had diabetes, and kidney function was average, was just the upper limit of normal, but there were some patients with very bad kidneys also. And this was this SF36 scale. There are physical function, role of physical, bodily pain, general health, mental health, emotional role, social function, and vitality. And we were comparing to normal other people in Finland. And here you can see that transplant patients were doing almost in all these questionnaire questions better than average Finnish men, 55, 60-year-old men in Finland. It's only a little bit difference in bodily pain, but otherwise extremely good results. I think that one reason is that these patients are very sick before the transplantation, and then when they get better, they are very happy with this, what they have received. Here you can see what is the difference. Emotional role is very good, and mental health is very good, which is very interesting. And here are general health, activities, vitality, and social functions. There are small difference. And their physical function and physical role. They are all together, and we can say that most of our patients were very satisfied. There was 28 who were satisfied, and only one patient was not satisfied. What are the problems with after transplantation? And they also affect the quality of life and happiness. There are 18% had osteoporosis, 14% diabetes, 86% hypertension, high blood pressure, only one malignancy. Most of patients were in NYH A class 1. It means their function was normal. Only 12% in class 2 and class 3 only 1%. No one was in class 4. And ejection fraction was that normal. But gastrointestinal symptoms are very common after transplantation, and they are mostly related to immunosuppression. They are diarrhea, they have constipation, indigestion, they have very often reflux, they are gastroesophageal reflux, and these are the problems. And here is, well, actually we went through this. We can jump up. When we are taking together all gastrointestinal symptoms, it's meaningfully lower, but they have meaningfully lower values in heart transplantations when compared to matched population. That is the big problem. So, as a conclusion, we can say that quality of life after transplantation is relatively good and comparable to the age and sex-matched reference population. Quality of life is vulnerable and susceptible to side effects caused by obligatory immunosuppressive regimen, where GI symptoms probably play a major but underestimated role. So, we should be aware of immunosuppressive-related GI symptoms and recognize the important impact on postoperative quality of life. And therefore, the patient should be treated well, and we must check the immunosuppression, and if necessary, we can change them as long as we get the quality of life better. What are the exercise health benefits? There are quite many studies actually which show that positive the exercise after heart transplantation or any other transplantation is beneficial, but we don't know so much about how are doing especially heart transplant patients and lung transplant patients, and it is not well known what is the frequency or intensity that provides the greatest benefits. We know with the normal people that high intensity interval-based aerobic exercise is superior to when we compare to moderate exercise. And we know that after transplantation, capacity in the range of, is in the range of 40 to 60% when we compare to normal values. and we can improve it by exercise. And after lung transplantation, as I told you, is the big problem muscle dysfunction, atrophy, weakness, or changes in muscle composition and metabolism. It is the problem when patients are really very sick and they can't practice exercise for a long period before the transplantation, and then it takes a long time to get it back even to the normal, that before transplantation. Of course, hospitalization due to infections or rejections and immunosuppressive medication, they impact on muscle function also in these lung recipients. So, as a conclusion, I would like to say that it is not only the transplant, I mean the organ transplanted. It is not the most important thing to limit our exercise tolerance. There are many more. There's immunosuppressive drugs, they are the other diseases, and they are the problems with rejection. And also we must remember that younger organs are doing better than older organs. Therefore, we prefer to use younger organs, and especially with younger people. Thank you.